Thank you for joining us for this webinar, the title of which should be on your screen now, looking at the importance of a national accreditation programme for memory clinics, insights and learnings from both the United Kingdom and Australian models. My name is Matt Paradise. I'm an old age psychiatrist and researcher with ADNET. So I'd like to start with an acknowledgement of country. The Australian Dementia Network acknowledges the traditional custodians of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to all Aboriginal and Torres Strait Islander peoples, their cultures and to their elders past, present and emerging. Hopefully by now, most of the participants know about ADNET, but actually I gather we've got quite a few people hopefully dialing in from the UK, so they may be less aware of the programme. So ADNET is a dementia research collaboration throughout Australia, funded primarily by the NHMRC, our equivalent of the MRC, 18 million Australian dollar over 5 years. It has three main connected arms. One is a clinical quality registry. Two is the memory clinic arms, of which this webinar series is initiative. And third is a clinical trials program, which aims to develop a standing trial-ready cohort of highly characterized people at risk or living with MCI or dementia. So we're always looking for clinics to participate in the ADNET registry if they haven't reached out for you already, and you can contact them on that email. And we've also got a list of memory clinics and associated services really all around the country. That's hosted on the ADNET website, so you can certainly go and have a look and see what's on there. But also, if you haven't, if you want to increase visibility of your clinic and your service, please let us know and you can register to be on that map as well. And it's worth saying that that's a whole variety of services, both public, private, research-based, and so on. And we've also developed a neuropsychological norming tool, which is available for anyone to use once they register. So again, please look on our website and there's a link there. And all the details are on our website. So I'm very excited to introduce Professor Martin Orrell, who I think may be the first international speaker we've had on this webinar series. So many thanks for agreeing to talk to us, particularly at this time in the morning in the UK. So for those that don't know, Professor Martin Orrell is the director of the Institute of Mental Health, a partnership between the University of Nottingham and Nottinghamshire Healthcare NHS Foundation Trust. He led the research to develop and evaluate cognitive stimulation therapy, CST, for dementia. This is now established in NICE dementia guidance and is in use in 30 countries. He's been awarded 7 major dementia care research grants totaling £17 million and has published over 350 papers. From 2009 to 2023, he was chair of the UK Memory Service National Accreditation Panel, MSNAP, which is primarily what he'll be talking about today. He is an NHR senior investigator, president of the European Association of Geriatric Psychiatry, and editor of the International Journal of Aging and Mental Health. He's also a board member of INTERDEM. It's a pan-European network of researchers collaborating in research on and dissemination of early, timely and quality psychosocial interventions in dementia. And then after Martin, we'll have Inga, Dr. Inga Mehrani, who many of you know from her work here at ADNET. She's the project manager for the Australian Dementia Network Memory Clinics Initiative. She's a trained speech pathologist and therefore developed a keen research interest in the improvement of diagnosis and treatment for individuals with stroke-induced and neurodegenerative language impairments. In 2018, Inga completed her PhD in cognitive science as part of the International Doctorate for Experimental Approaches to Language and Brain at Macquarie University and the University of Groningen in the Netherlands. Her most recent research focuses on speech planning processes, i.e. conceptualization, and possible conceptualization deficits in speakers with stroke-induced and primary progressive aphasia. So it should be a great talk. I'll now hand over to Martin, and then I'll come back at the end for the Q&A.
Thanks very much. I'm delighted to be here. It's very exciting to hear about the Australian Dementia Network. And this is the official logo. That's me. Next slide, please. So launched in 2009 to support memory service to improve quality of care. It's not for profit, it's a subscription service, and looking at how to, it's quality improvement to improve services using standards with self-review and peer review, accreditation, and opportunities for learning and sharing of ideas. Next slide, please. So how we actually started this was that we got funding to do a scoping exercise from the Healthcare Commission. We had a one-day workshop, and we came up with 2 ideas that we thought were priorities for national audits. One was memory services, and one was the care in general hospitals for people with dementia. And so we had some initial funding, did a literature review, Delphi exercise, a wide consultation, and we got some funding from Northwest England to do a pilot. They had some money, and they said, well, we'd like you to pilot your memory services standards in our area. And then we had an event on the feedback. We made revisions. We had the first edition. Next slide, please. So from the initial pilot, as you may know, in the UK, the Accreditation network's a subscription service. So we basically wrote to all the memory services across the UK, which was over 100 at the time, and we said, would you like to be part of a quality improvement network for memory services? There's a subscription fee for it, and this is what we're likely to charge, and we'll need 30 clinics to start. So we managed to get, because 30 was the minimum to have a kind of break-even memory services program. So actually that worked out. So we managed to get the more than 30. So the Department of Health regard MSNAP as a way of ensuring quality, and also the commissioners say that it helps to tip the balance about whether to fund the service or not. And more GPs can access the service compared to in 2007. So it gives better access for people with dementia. It's a part of the drive to get the diagnosis rate for dementia increased, and also as part of trying to ensure that other types of dementias, rare and complex dementias, are well served. Next slide, please. So early on in the MSNAP journey, the Prime Minister called for services to get more involved in research. We brought in 2 new standards. One was to inform people about research, and the other one was to have a register for people who are interested in research opportunities. That's now been rolled out nationally as the Joint Dementia Research Register. Next slide, please. So from the start, we've included people with dementia and family carers in the quality improvement program. They're members of the steering group. They help to pilot some of the questionnaires for carers. They're involved in the reviews with peer review teams, involved in consultation. They're represented on our accreditation panel. And so they're all part of the process from the start and all the way through. Thank you. Next slide. So some of the feedback from carers in terms of their experiences, whether they want a nice environment, not just a prescription and then saying goodbye to somebody. They want information and support, and they want to meet others, and they'd like to be able to make choices at the right times. Next slide, please. So we've now got 85 members across 41 trusts in the UK. It's widely spread, but there are some patches of the UK that are more widely involved than others, the north and London and the southeast and the southwest. The Midlands, actually, where I am, is not so well represented, but these things take time. And we're now looking to develop more international links. Next slide, please. So some of the things we found is actually the caseload of memory services has gone up over time. That's over about 10 years. Per individual service. Next slide. And that's probably a good sign, because that suggests that we're getting to more people. Also, the waiting time between referral and first assessment has gone down. Now it's about 5 or 6 weeks. And I think our target is that most people will have a diagnosis within 6 weeks of referral. So clinics vary in their practices, but I think that if most people can get a diagnosis within 6 weeks of actually the referral going out, that's a reasonable objective. Next slide, please. So there's 2 different types of accreditation. One is the full membership, where you have the people have to meet all the standards. You have the peer reviews every 3 years, the report on the services, and there's a check on the documentation. And the second one, which is to encourage people to join, is called the developmental membership. So these are services which are new to MSNAP, and perhaps they're not sure if they're going to meet all the standards. And so we'd work with them closely to help get them ready to actually apply for accreditation. Now, if people follow the process, it's not really like an exam that you pass or fail, but there is, after the initial review, there'll be feedback about what needs to be fixed. And if people fix the requirements for the standards, which is, it's not always easy, but it's straightforward, then, you know, generally all the services that start will get accredited. And if they're not accredited, then there's 1 or 2 red flags that they really need to sort out. Next slide, please. So we've got 180 people across the UK who are peer reviewers. There's a wide range of disciplines. We hold free peer reviewer training sessions. And one of the benefits is actually people involved in MSNAP can also go around and see and review other services. You could see it's very multidisciplinary, which is good. And, you know, the opportunity to see how different services work. You may have things that are structured differently, organized differently, but they still fulfill the standards. Next slide, please. The standards are developed in collaboration with the member services, and they're reviewed every 2 years, and they're updated. And some of the standards are chucked out. There was a range of generic standards from the Royal College. We thought, well, we should have something that's more specific for for MSNAP. So we managed to reduce some of the standards, which is good, and aim to describe what best practice is. And this is freely available on our website. Next slide, please. So there's 3 types of standards. Type 1 are ones that you must meet. So you're expected to meet 100% of type 1 standards. And these may be things like somebody has somebody's had a physical examination as part of the assessment of dementia. It's about, you know, people being treated with dignity and basics of care. Type 2 are standards that all accredited services would be expected to meet, but you don't have to meet 100% of them. But those would be things like how long the how long the wait is, not more than 6 weeks to be seen, and a range of things in relation to that. And type 3 standards are aspirational, and we regard these as the kind of the cherry on the top, if you like. So you only have to meet 60% of these. And these may be things like people receiving a personalized letter, or after they've been to the clinic. So something which requires a bit of extra effort. Next slide, please. So, so there's been a report which is again available online about commonly unmet standards. It's one which might be useful to have a look at. We get some standards coming up again and again as unmet initially. These may be things like actually consulting with patients and carers about the quality of care in the service. And there's a variety of ways of doing this. There's a brief questionnaire that you can send out, but also people might want to organise some groups of people with dementia or family carers talking about the service, think about how they can improve it. And on average, 89% of all the standards are met. Now, we have had some services that meet 100% of the standards. We used to be able to give them an outstanding rating, but now they've changed the rules, so we could just pass or fail people, but we can tell them how good they're doing. Next slide, please. So improvements against standards, more referrals seen within 4 to 6 weeks. Next, more people being asked if who their diagnosis could be shared with, more staff having funding for training, and more referrers knowing what the protocols are. Next slide, thanks. And you go down that. So some of the things actually that would benefited the standards was that they could use the assessment process to put pressure on the hospital or the commissioners for key things that they needed. I mean, one was, you know, so each site will have access to a physical examination unit. So you can actually, if you need to do a physical examination, you've got the facilities there. Having a medical lead for the service as part of the MDT, that's considered essential. Better information packs. Sometimes there's been issues about perhaps fairly old buildings where they're not properly soundproofed, and so you don't want somebody going into a clinic where people in the corridor can hear what's going on. Having a checklist for assessments. Next. And speeding up shared care. Next one. And so this is the process. So there's the self-review assessment. There's the external peer review. There's a report. There's action planning that goes with the report, where you go back to the service and say, well, these are all met, and these ones you need to do some work on. And then once they've responded to all the standards that they need to fix, then it comes to the committee, and there's a decision made on approving them as an accredited service. Now, sometimes there's some debate about whether they've met a standard or not, and if necessary, we may defer them and say, well, you've nearly met this, but you still need to get the clinic room sorted out. And so they might be asked back again to come to the next committee meeting in 3 months. So generally, if people haven't quite made it, they're deferred. And but it does focus the mind if they've invested so much in the review process to get things sorted out. Next slide, please. So this is the how the review works. There's a case note audit, looking for making sure that things are documented, making sure that people are asked about things, patient and care and staff questionnaires. There's a referrer questionnaire as well. There's an organizational checklist. I mean, one of the things that comes up is if people are asked about their hearing and their vision. So it's not that we expect them all to do vision and hearing tests, but they ought to know whether there's a hearing or vision issue. Then there's the peer review and then feedback from that. So they have some feedback on the day, then they have a written report. And then it goes to the accreditation committee, where you have the Royal College of Psychiatrists, the British Psychological Society, Royal College of Nursing, Alzheimer's Society, and also the Royal College of OT. So it's a very multidisciplinary accreditation committee. It's been long established now, and I'm still on the panel myself, but I've finished my chairing of it after 15 years, which is probably long enough this year. Next slide, thanks. So, so some brief notes on the feedback. So patients and carers felt that there was enough time to explain the assessment. Diagnosis was given in a sensitive way. Staff communicated with them adequately. But there was some patients and carers felt they needed a little more time to discuss what was going to happen in the assessment before it happened. Next slide, thanks. So we've done some research on the standards over time, and we looked at patients and carers' views, and you'll see at the end there's 3 research papers that come out of it. And this was very important for me, was to make sure that we had a robust process, which was then had good validity and good evidence. And so actually the research was kind of backing up the overall process. And we found, so it's a large-scale survey across 21 memory services. They're very satisfied with the diagnostic process and the staff. Sometimes a lack of written information. And carers appeared better informed about symptoms and prognosis than people with dementia were. but interestingly, carers were also more stressed about treatment decisions. Next slide, please. So we had excellent versus accredited services some time ago. We were able to compare the patients and carer views from excellent and accredited services. And I guess the assumption was that excellent services should do better on a number of features. Next slide, please. And so as you can see, excellent service overall did better. People were more likely to have information about the course and prognosis of the condition, about local services, about general information and advice, about medication, also about non-drug intervention. So as you could see at the bottom, actually, although excellent services were better than accredited, it was actually non-drug interventions where people, still felt there was room to know a bit more. Next slide, please. So we also had patient questionnaires. And again, there was a general pattern that excellent services did better. And again, there was better information from excellent services. But again, at the bottom, as you can see, it's non-drug interventions where there was scope to inform people better about what was available. Thank you. Next slide, please. So we had close to 600 questionnaires from the 41 services. They'd given it feedback. They found it easy to get appointments. And so people had good experience of memory services, whether or not they had regular or excellent accreditation. And so this suggested that the accreditation process is a valid and robust indicator of memory services quality. Next slide, please. So why accreditation? You can promote best quality improvement and best practice, help plan for the future, demonstrate the quality of the service, and benchmark yourself against other services. Next slide, please. You get a comprehensive report. You can visit other services. There's the MSNAP annual conference you can come to. Next slide, please. And we've had excellent feedback. Feedback from the services about how much they've benefited, realizing what they actually do and what they've achieved, having a valuable experience, sharing ideas on service developments, sharing other ideas, and also the virtual reviews went well. Next slide, please. And then patient and carer feedback, always treated with dignity and respect, greatly benefited from visiting the clinic, and so generally very positive. Next slide, please. And so these are three papers, if people are interested, on looking at patients and care reviews of the services and also how we develop the services. So as colleagues, I work with Sophie Hodge, Emily Doncaster in particular. Thank you very much. I think that's it.
You will realize that there's lots of overlap between what you just heard from Martin and what we're trying to achieve here in Australia and what we just started with over the last 1.5 to 2 years, really. So I'm very glad for this opportunity to give an overview of the Australian system that we're just establishing as well. When we think about memory clinics in Australia, there was a very interesting study from Genevieve Steiner a few years ago where she asked primary health care clinicians about what their idea of a memory clinic is when they think about it. And the overwhelming majority was really talking about this idea of a one-stop shop that has a specialized assessment, that is multidisciplinary, that provides case management, that provides interventions, pharmacological as well as non-pharmacological, and that provides support and education as well. When we looked at the reality in Australia, we see that it's a lot more disenfranchised, really. So what stands is the core of the memory clinic service as a highly specialized assessment service that is very good at what it's doing. We see multidisciplinarity as a core feature, but not always in-house. We also have memory clinics that have kind of more creative ways by creating referral networks and enabling this multidisciplinary assessment, but yeah, by using resources not just within one clinic, but in the surrounding clinics. And we do have pharmacological interventions, as far as available, are offered. Medication reviews are offered, but that's sort of where it stops, and where resourcing for memory clinics also stops. So the reality looks still a bit more different than what kind of this ideal image of a memory clinic is. What else do we know about memory clinics? So we did a mapping effort since AdNet memory clinics commenced in 2019. And since then, we have 150 specialized services. I'm pretty sure we're not mapped all of the specialists, also including single specialty services. But we have 86 multidisciplinary services mapped currently, with 54 of them being in the public system. But only 13 public memory clinics being outside of major city areas. And when you look at the map, you see that there's large gaps in the rural and remote areas in terms of equity of access to these highly specialized services. We also know that there is a greater need for harmonization. We did some surveys that showed us that we have a large variability in the staffing of those clinics, in the frequency. Our waiting times are pretty high compared to international services. So you just heard from Martin that it's on average 33 days in the UK, so 6 weeks. We found an average of 10 weeks in our surveys, but there's individual ranges from 1 week, but up to 1 year and more in more regional areas of Australia. We also find that there's only a third of clinics being able to provide any non-pharmacological post-diagnostic interventions. And that's usually just one session, so really nothing ongoing that supports the clients. And we also looked at research opportunities that are offered through the memory clinics, which we see mostly done in metropolitan services, probably because that's also where the research is available. So to address this large variety and the need for harmonization, we started to consult with health professionals, memory clinic clinicians, and people with the lived experience of dementia and MCI and care partners to set up these guidelines for memory clinic services. We reviewed the literature and conducted this consultation process in form of focus groups and email consultation surveys with the ideal to arrive at a similar document as the one that Martin just presented to you. We also arrived at around 150 consensus-based standards for ideal service provision, and the guideline in its current format is also still available on the AdNet website. We had over 1,500 downloads this far, and also a few downloads for this client guide that we particularly developed for clients with dementia and MCI, clients that are seeking a memory clinic assessment, just as sort of some overview of what to expect. And then after we launched the guidelines in November 2020, it kind of had the fate of many guidelines in the health system. It kind of started to collect dust on the shelves in the hospitals. So the next step for us was to think about how can we facilitate implementation and really make clinics trying to implement this and check their current service provision against the guidelines. That's where we started to develop the monitoring and quality improvement pilot. So that's the MQIP, which is kind of a pre-study for a potential accreditation of memory clinic services. So we reached here out to 18 memory clinics across Australia that we previously worked with, and found 8 clinics that agreed to participate in this little trial from 6 different jurisdictions. Other clinics that declined to participate, we're usually citing kind of time and staffing shortages, or the responsible clinician who would like to engage was going on extended leave periods, so these type of restrictions. The aim of this MQIP program was really to see what this initial framework that we set up for guidelines evaluation, memory clinics evaluation, how is that performing and how good is it doing in identifying systemic barriers to implementation, but also to see how well are the seminal guidelines doing. So similar to the pilot that the MSNAP was undergoing, to really identify some maybe innate issues with the guidelines that makes it difficult to implement some of the standards. So our MQIP process included an initial training workshop that all of the clinics attended. We had a self-evaluation process that I talk about a little bit in a minute. The research team would then go and look at all the data and analyze the data and prepare a site-specific report for the clinics. And we do have a final clinic meeting where we discuss the report and the results with the clinic, got some feedback on the processes, discussed some issues with the guidelines, but more about that in a minute. So the framework was set up in Excel because that was sort of the easiest accessible tool for us to set up this larger data collection framework. We first asked about some context information, also to know how to interpret the evaluation results later. It was really interesting to know where the clinics are situated, what their staffing is, how many patients they're seeing, these types of context information. A clinician or a clinical administrator would then go through the self-assessment part of the framework, where we would really list every single standard that was included in the guideline and look at a self-rating where the clinician thinks it was achieved, not achieved, partially achieved, and give us some explanations of why that was, and also cite some barriers when there was something on the top of their head. Here is the example of waiting times, which we included as for priority and non-priority clients. And the clinicians were also asked to upload evidence to support these ratings so that we didn't have to just rely on the word of the clinicians, to also see how these standards are implemented in clinic routines, in the model of care, in flyers, in templates of letters they're sending out, assessment frameworks, these types of information that gave us more information about how the standards are exactly implemented. And the clinicians were then asked to complete a case note order to get us against the subset of the standards. That was asked for the 8 most recent clients diagnosed with dementia and MCI, and the 2 most recent review patients. Here, just outlining if the standard was achieved for this patient or not, and explaining why not. Our results showed that we had 7 out of the 8 clinics were able to complete the MQIP within the given timeframes that we had. This one withdrawal was because they started the process and then found out that they had to do some internal ethics processes just as a governance additional to the ethics that we had, and that was accepted by most of the participating clinics. And this kind of additional time constraint was not really planned, and so they couldn't complete the MQIP. We had one of the clinics was categorized as coming from in a regional area. We had 1 private clinic participating and 1 single discipline clinic that not technically fulfills the memory clinic's definition, but who's really interested in participating to see what is required of a memory clinic according to the guidelines, where they're standing now, and what would be a possible pathway for them to becoming a multidisciplinary clinic. We also have staffing at those clinics between 1.4 and 3.8 FTE. Overall, we found that the clinics were able to, on average, achieve 56% of the standards, with a very wide range of from 18 to 87%. So here, interestingly, we saw that the single discipline clinic had the lowest ratings, which was in a way expected and good for us as a measure to see that those guidelines are really able to pick out the specialty of the memory clinic services versus single specialty clinics. The sections with the highest achievement rates were things like diagnostic workup, which is really high level, the recommendations around providing a comprehensive assessment, looking at the ratings of IADL, instrumental activities of daily living, these sorts of things, looking at pharmacological support and communicating the diagnosis. Those were the highest achieved. The lowest achieved were around case conferences, dignity and consent, which might sound bad, but is really one of the most contentious areas in the guidelines throughout the development and implementation, because that's around what to do when the client doesn't want to know the diagnosis, what to do if the client might not have capacity and the support people don't want that the diagnosis is communicated, and views around what best practice is there differ widely. So that's why the low ratings here. and also around neuropsychology assessments. The most common barriers to implementation were staffing and resource restrictions. That was named as the top reason. Some standards were also not considered essential for high quality, so clinics felt like that's not really needed. It was also sometimes that the compliance with hospital processes would go against guideline compliance, so particularly around some referral processes where the clinics felt there's not much they can do about changing it because that's what the hospital dictates. Sometimes the clinics reported that they implement certain standards, but we couldn't get any real proof for it over and above the word. So we would have needed more qualitative data to confirm everything that was an issue there in the framework. And sometimes standards were just outside of the scope was reported. So follow-up appointments for all clients with dementia is just something most clinics can't really do. They don't have the staffing, they don't have the resources. So it kind of goes back to this first point. Feedback on the guidelines that we received included that there was some ambiguous wording standards which need to be rectified. In this case, where we kind of asked for two things in one sentence, that was a bit tricky. And that we had too many sections with too many substandards. So as an example here, the case conference, each individual topic that we recommend should be discussed in case conferences was listed. And often clinics lost a lot of points here because they don't include all of that because it's sometimes not relevant for every patient. It's not part of their usual checklist for case conferences. So yeah, that was a big issue that we would rectify in the second version. Feedback on the framework generally was that the clinicians really enjoyed the opportunity to review the internal processes. And we're really also interested to compare themselves against other services. So I think the most interest we got was around were there any CADMS clinics and how did they do compared to us. At this stage, we didn't say anything about those, of course, just in this pilot, but we noticed that this was kind of a big interest for clinics. We also had clinics, most clinics identified opportunities for immediate improvement, things they just didn't really think about earlier, like preparing a welcome pack with information about the assessments for clients pre-assessment. And some clinics felt really that the results validated the quality of their service and their work. Negative feedback on the framework was that there was a bit of an imbalanced rating, and this was usually due to the high number of substandards, which give a lot of weight to things like the topics that are discussed in the case conference, where it's probably not really warranted. So that was an issue in the way we analyzed, we rated the standards in this initial version. The documentary evidence that we were asked for was sort of mentioned as being out of touch. We can't provide all of these documents. We don't have the time to write all these protocols. It is clear to us, but we can't prove that those are the protocols. So there was a feeling that the low performance rating that came out of the MQIP was not really reflective of the true quality of the service, which of course is a big issue for such a framework. I think all of the clinics felt that it was very time consuming to do this. We gave the clinics 2 months to complete it. And we had clinics usually taking about 30-40 hours to really complete this, which of course is a huge ask additionally to all the clinics' work. And we had some issues with the system itself, and clinics participating in the registry also felt that they were a bit kind of double recording data, which we also acknowledged from the get-go as an issue. It was just not possible in the pilot phase to integrate the registry a bit more. So our learnings is that the MQIP could really confirm the large variability across the memory clinics that we found in the surveys, which was a good thing for a start. We feel that the interpretation of the MQIP results really needs to be clarified. So there is, what we found is that low performance ratings in our MQIP was not always what was usually not synonym with the low service quality. They were still very good in what they were doing in their core services. So we need to really flesh out how the MQuIP can be more representative of true service quality. And things like getting additional qualitative data from patient care surveys like the MSNAP is doing as well. Ideally, things like a peer review, which I would really like to see and would be thinking is really interested, just to get these additional layers of data that give us a better picture of the service quality. And clinics were also fearing if there's any implications for clinic funding when we come back with a kind of bad result in this MSNAP, in the MQuIP. So minimum standards, what really clarifies high quality needs to be done. We need to be able to reduce the completion time and add more qualitative data resources. Establish a more formal accreditation committee or some form of committee that really analyzes the evaluation with more experience and weight behind them than kind of just our research team. And the streamlining with the registry was a big point. So we're just in the process of reviewing the guidelines to do a second version that has a reduced version, really focusing on the essential standards and reducing all the substandards that may not be seen as essential. And we will also add sections for clients with diverse needs, which is not something that came out of the MQuIP process, but what was sort of planned already for the initial version of the guidelines. But we just didn't get the right input from the right people with experience back then. So that's what we rectified now. And included in the new version, we will include standards for people with intellectual disability. We did focus group and email consultations with health professionals, with people with the lived experience, and came up with 50 new standards that will be included. That is around clinics first and foremost considering referrals based on the individual needs and not just rejecting it because it's a client with intellectual disability, around clearer protocols and things like easy read information. We did a similar consultation process with health professionals and lived experience experts from COLD backgrounds and arrived at 8 new standards that we will include that is around information, around assessment processes, around the use of interpreters. Our future directions will be that the revision process for the guidelines is currently in process. Some of you might have seen a survey going around as a last consultation process. The launch is planned for next month, and we're refining the MQuIP and framework and looking for funding opportunities to have another go with a more refined system, more similar to the MSNAP and their success model, to get that rolled out across Australia. And at this point, I thank my team and I thank you for your attention.
Thank you very much, Inga. So interesting to see the similarities and differences between the two processes. I guess MSNAP's been going for 15 years and we're just setting up for the first time. But also I think the heterogeneity of memory clinics in Australia is quite a challenge. Obviously we've got lots of different states and jurisdictions and historically different ways that services have developed across this nation. So we've got a few questions come in already. I might start it with some questions for Martin. But you mentioned the international accreditation. I think your slide said it certainly wasn't necessarily given the tick by the college, so to speak, but I didn't know if you could talk a bit more to that.
Well, I think it's a bit of an experimental stage at the moment, but I think the idea is that they're open to working with memory clinics internationally. I don't think we can accredit them in the same way, but I think in terms of the standards are available online, which people can look at. And so I guess if one of the questions might be, well, how would we do the peer review? But you could have for example, I guess if you had a country like, say, Malta with a few memory services, you could see where we might be able to train some peer reviewers and they could go around and assess each other's services, and we could give them some advice on, how to put it all together, if you like. So it's not really taken off yet, but it's an ambition, and I'm hoping to be the coordinator of international work. But it's one of these things as you can imagine, I've been talking to presenting on the memory services over the years. And although people may be interested, it's rare that somebody, kind of takes it on and wants to do what I think you've done fantastic work in Australia. It's very exciting and terrific stuff. So, I mean, like you said, we've had a head start.
Thanks. I also had a question about the number of standards. I think you had 154, which was similar to our 150.
That's right. Yeah.
Some of the feedback we were getting was just too many kind of data points. Now that might just be kind of an expectation of the process generally, that people are more familiar and willing to kind of engage with MSNAP. But are all your standards assessed, or are some thought not accessible in the accreditation process?
Well, generally they're all assessed, but sometimes some standards, and I can't tell you off the top of my head, sometimes may not be appropriate for a particular service, but mainly you could expect 90-95% of them to be assessed in any particular time. But you will, there's some instances where if a service is kind of well organized and they have a pro forma that they complete and they have a very systematic approach to assessment, those kind of things you can get through quite a lot of standards just by being well organized and making sure that you ask people if they want to, would people like to know their diagnosis? Would you like the family relative carer to know? So some of these things can be actually done very quickly, providing you can evidence them. And I think evidencing them is for each of the standards we have, there's a way to find the evidence to meet it. And so I suppose one of the things that came up with your standards is that, well, everybody agrees this is a good thing. How do you measure it? And in a sense, if you can't evidence it and you can't measure it, you can't really keep it. Because, well, of course we do this, but it's, one of the things actually, like I said, it's about, if we say asking about people's hearing and vision, if you have a checklist where you say, do you have any problems with your hearing or vision, kind of yes or no, and then that goes into, then that covers it. But another alternative is actually to say, if they don't have that, then there's an audit of the case notes, and you can say, okay, we've looked at 10 case notes, and in each of these, there's a note that people have been asked about their hearing and their vision. So it could either be the audit or it could be a system that they use.
Yeah. Okay.
And of course, audits are quite a good way of checking that people really are doing what they say they're doing.
We'll go on to some of the questions from the audience. There was a few questions about the actual external review process. One question: do people living with dementia and/or their carers have a role in the review process itself?
Yes. I think it's more often than carers, but generally, I think you'd have a member of the public involved in the review, the actual physical review, going to the service, talking to the staff, having a look around. And if you had a family carer, they may talk to a group of family carers from the service about what it's like, what their experiences have been. So yes, it's harder often to include people with dementia, but they are included where they can be. And we have had them on the accreditation panel, for example, in the past. But I think these all the way through, really, we've involved patients and carers.
There was another question.
Carers really value that. They really like to be asked. Yeah. Sorry, carry on.
No, I was going to say, I think you answered another question. What does the external review process look like?
Yeah.
Do reviewers, would they generally do just kind of one memory clinic, or they do a whole series in a given year?
Well, I think they get trained, and then I guess if people are trained as reviewers, we'd expect them to do some of the memory services. There's a capacity limit about how many people could do a year. I think that if people did, you wouldn't expect them to do 10 a year, but if they did 2 or 3 a year, so you constantly need to be providing a training for additional reviewers so that you've got your numbers up. And in a review, you may have a family carer, somebody who's been a memory services manager, and a clinician, and then somebody from the MSNAP core team. So there's probably 4 people. So 2 people from a regular memory services part of the thing.
Okay. There's just a quick question about the medical assessment unit. I think they wanted clarity over that, as opposed to why could not a room with a single high-low table be used instead?
Well, I mean, I think when we talk about, if we use the term medical assessment unit, I think we meant there's a room where you can examine people clinically, you know, and take bloods if you need to and things like that. We're not talking about a new, you know, like, I know sometimes in hospitals, a medical assessment unit means a, you know, a kind of inpatient unit, things like that. And we're just talking about having a well-equipped room with the things you need to check somebody's over physically, you know?
There's a question. Do you have a policy? Do you have policy review tools, frameworks, or resources used by accreditors that can be shared? I mean, obviously the standards are publicly available.
I think, I mean, yes, I think if people wanted them, if you came to MSNAP directly, I think we could make them available. There's no, I think this has been something we want to do, is be able to share our, you know, share our processes and, you know, I mean, events like this where, you know, we talk about what's happening with Australia, you know, that's kind of, that it's good for the NHS to be, you know, passing on, you know, useful policy and useful approaches.
Thank you. Inga, I might throw you a question as well. But there's a question from a neurologist. She's a neurologist in a public hospital. Is there guidance for clinicians wanting to set up a memory clinic, mainly to help navigate the hospital system that tends not necessarily to support services like this? So this is a question I guess we have got at various times. You know, I guess what's ADNET's role and the memory clinic's role in helping support aspiring or developing services?
Yeah. So the guidelines were definitely seen by such services as a good starting point, just to see of what is generally expected of such a service and kind of which boxes is the service already ticking, because there is probably single specialty services that, around diagnostic processes, when you work closely with other disciplines in your area, you might be ticking many of the boxes already. I think the other guidance then is a more policy-oriented issue that is very individual, and we can't give that much guidance on that at the moment. So what we're running in some of the areas in Australia is looking at like really localized need. What is the estimated number of incident cases with MCI and dementia? What is the current capacity of available services? And kind of have this data-driven approach to prove need for such a service in the area. That's the way we're currently trying to go. But yeah, that's very difficult to do for every single clinic that might want to do this. But we're hoping in the light of the National Action on Dementia Plan that was going around as draft consultation end of last year. I don't know who has seen that in the audience. There's also a call for more memory clinic services. So there might be a policy drive, and it would always be good to kind of talk to the local health district and see what they think about it.
Thank you. And I guess related to that, there's a question from Sharon Naismith, who's one of the co-directors of the Memory Clinic initiative. Martin, thanks for your terrific work and for generously sharing your experience with us. Keen to know if you have any tips for putting pressure on the health system or policymakers to drive improvements or clinic expansions. Have you relied on individual clinicians, or is this something your team gets involved with?
Well, I think I'll just say hi to Jamini here, who I see is on the call. She's from the MSNAPers team at the Royal College. I think having a process of accreditation, and I guess one of my questions for you with the MQIP standards was, well, at the moment, do people pass, or do you just give them a kind of rating? Because having a process of accreditation, which is then nationally recognized, was very helpful, because we could also say to people, well, we can accredit you, but you've still got 2 outstanding standards to meet. So you still need to do a survey of patients and carers, or you still need to do this. And then actually, you know, getting accredited, getting a certificate, having national meetings. I mean, something that people can take back to the service or take back to the hospital and say, look, you know, we're meeting top quality standards, you know, recognized by ADNET, and this is important. also, of course, having sometimes people might talk about their memory services to, you know, how well they're doing to the local paper or the comms in the local hospital. Feedback from patients and carers is very valuable. So I think these things are useful levers, and I think that if you can, like I said, move to a process of accreditation, I don't know about whether people would like a kind of subscription system like we have, but it's usually, I mean, it's quality improvement, so it really does drive better quality in the services, and we make the case really that actually all services should be looking to improve their standards and meet kind of minimum standards overall. And
did you? Oh, sorry.
Yeah.
I was just wondering, did you have an example in mind of kind of clinics that were not doing so well on the SNAP and then were able to use this to put pressure on the policies for more funding for?
Well, yes, some of the things. I mean, sometimes they can just change their systems really, but sometimes, as for my slides, one of the clinics didn't have a physical examination room. We said, well, actually, you need something where people can have a physical check, you know, especially if somebody gets ill in the clinic or something like that, and or soundproofing in clinics. You know, clinics, it's like, well, you have to organize the clinic so people in the waiting room can't hear what's going on in the actual clinic room itself, because there's issues around dignity and privacy. So yes, with those particular things, also things like having access to you know, specialties like, say, clinical psychology or neuropsychology. And one of the standards is not necessarily that you have to have, you know, you have to have access to specialty advice for certain things, and it varies according to the discipline. But if you can show, you know, if you show that you've got access to neurology services for complex cases, or you know, things like that. So it's not necessarily everybody gets it, but you can demonstrate that actually you've got access to, say, young onset dementia services where it's needed, you know.
Okay, well, I think actually we need to wrap it up there. Gemini, who works for MSNAP in the UK, has answered some of the outstanding questions in the Q&A, which is great. Yeah, many thanks for that. And thank you to our panelists, Inga, and in particular Martin, obviously from doing this from overseas at a fairly early time in the day. I'll just share my screen. Hopefully by now most people know about the guidelines that are available to download online. And please contact us if you have any questions about the content of today's discussions, or you're just interested in knowing about the initiative in more details.